Medical education takes place in a volatile clinical environment. A ward operates under high pressure, severe time constraints, and constant physical motion. Clinical educators perform a dual task. They must solve complex medical problems while simultaneously externalizing clinical reasoning for a novice learner, all while the clock ticks. A common professional assumption is that clinical teaching is an innate talent, or that instruction consists of letting a student shadow on rounds to absorb diagnostic intuition through proximity. However, unstructured observation produces mimics rather than independent practitioners. When the stakes are high, relying on imitation rather than a structured framework for reasoning leads to diagnostic errors and hesitant decision-making. For Ayush educators mastering the NTET syllabus, succeeding on the ward requires a transition to structured, evidence-based clinical frameworks. Effective clinical teaching is an applied, measurable science. It demands specific cognitive models to execute correctly, removing the guesswork from how students actually learn. The baseline of instruction is the memory level. This is a teacher-driven process focused on rote retention, where success is defined by recall accuracy regarding facts and definitions. As instruction progresses to the understanding level, students begin to identify relationships between ideas. They move from reciting facts to explaining scientific phenomena and solving basic problems. This diagram illustrates the ultimate target for the clinical educator, the reflective level. Sitting at the apex, this is a highly student-centered state where genuine critical thinking, inquiry, and real-world diagnostic problem-solving occur. Reaching this peak requires the educator to understand the specific psychological profile of their audience. Medical students are adult learners, and their cognitive processing is distinct. This introduces the core concept of andragogy, the science and specific set of principles dedicated to adult education. Under traditional pedagogy, adolescent learners are shifting from concrete to abstract thought, and their motivation is shaped by external factors and peer influence. Adult learners operate on a different behavioral axis. Adults require goal-oriented, practical instruction. They possess strong critical thinking skills, prefer self-directed autonomy, and rely heavily on their accumulated life and clinical experiences to anchor new concepts. The reflective level is achieved by applying andragogy. Treating adult medical students like adolescent learners ignores their intrinsic motivation and prior knowledge, which often leads to a breakdown in knowledge transfer. Understanding adult psychology dictates the actual communication channels an educator must use on the ward. Simply talking at a student is an inefficient method of transferring complex clinical skills. To address diverse learner profiles, the definitive framework is the VARK matrix. This model categorizes learning preferences into 4 distinct channels. The visual and auditory quadrants cater to those who process information through diagrams, charts, or spoken explanations. However, relying on seeing and hearing is insufficient for tactile physical diagnostics. This requires the remaining quadrants. Reading and writing preferences rely on written summaries, while the kinesthetic drive is learning by doing, engaging physically through practical activities and models. Traditional lecture methods isolate the auditory quadrant, ignoring the other learning styles. In clinical training, this single-channel approach slows down the acquisition of competency. To solve this, educators deploy innovative teaching approaches. These are multimodal frameworks designed to activate multiple VARK quadrants simultaneously. One effective structure is problem-based learning, or PBL. Instead of passively receiving a lecture, students work in groups to solve real-world clinical cases. PBL forces students to debate diagnoses, read patient charts, and physically examine evidence. It engages all VARK styles simultaneously, building reflective thinking and collaborative skills. Another strategic tool is the flipped classroom method. This operational approach is designed to maximize the scarcity of valuable ward time. The flipped classroom pushes rote memory-level tasks, like watching videos or reading foundational texts, to the students' at-home preparation. This reserves in-person class time for active diagnostic discussions and hands-on kinesthetic practice. Recognizing VARK profiles and utilizing these multimodal methods removes the friction caused by diverse learning paces. The student arrives at the patient's bedside intellectually prepared for action, but classroom theory must translate to physical reality. The ultimate test of an Ayush educator's effectiveness occurs directly at the patient's bedside. Unstructured, open-ended questioning during rounds consumes clinical time. Furthermore, it frequently creates performance anxiety in the student that can hinder learning. To execute teaching without disrupting care, educators use the 1-minute preceptor, or OMP. This structured 5-step framework is designed for bedside efficiency. Step 1. Get a commitment. The educator requires the student to explicitly state a diagnosis or management plan, testing their reasoning. Step 2. Probe for evidence. Asking why they chose that specific plan exposes the underlying logic supporting their decision. Step 3. Teach a general concept. The educator provides one universally applicable medical rule based on the case, ensuring the lesson scales. Steps 4 and 5. Reinforce positives and correct errors. Adult learners require immediate, specific formative feedback to accurately adjust their internal diagnostic models. While the OMP guides instruction, the complementary tool for assessment is the Mini-CX, or Mini Clinical Evaluation Exercise. The Mini-CX provides a short, focused evaluation of a specific clinical skill, such as a localized physical exam or history taking, rather than returning a broad, generalized grade. This targeted assessment is more practical in a busy ward, compared to comprehensive, long-form case presentations that attempt to cover every facet of patient management at once. Execution frameworks like the OMP and Mini-CX remove the chaos of the bedside environment. They transform the clinical encounter into a predictable, high-yield learning laboratory. These pedagogical theories and bedside frameworks do not operate in isolation. They integrate into a single, operational workflow. The progression requires understanding the adult cognitive profile, andragogy, to move students away from rote memory and toward the reflective level. Structurally, the educator adapts their delivery using multimodal methods to engage the diverse learning channels outlined in the VARC model. Finally, the educator executes at the bedside by deploying high-efficiency micro-teaching frameworks like the OPM and the Mini-CX to assess clinical reasoning in real time. This flowchart represents the unified mental model of the clinical educator. It systematically aligns learning psychology, communication channels, and bedside execution directly toward clinical mastery. Succeeding in the ward requires viewing the educational process with the same structured, diagnostic rigor applied to patient care. To complete this mental model, your next step in mastering the syllabus is reviewing how information and communication technology parameters integrate directly into modern clinical assessments.